Hey everyone, welcome, and thanks for joining us. It's so good to see you all. I'm Sharmin. I'm here with Jack for 30-minute Wednesday VMR. Hey Jack,
What's up, team? It's good to be back. Good to see y'all.
we are so excited, and I think John has a case to present. Is that right? Hey John, so nice to meet you. Do you want to introduce yourself?
Hey everybody, my name is John. I've presented a couple of times, I think two or maybe three. Really excited to be
Awesome.
back.
I think this is my first time meeting you. Can you tell me a little bit about yourself?
My name is John. I'm currently living in Baltimore, Maryland.
Nice.
Just as we all know, applications went out a couple of hours ago. Um,
Yeah.
yeah,
And you're applying this cycle?
yeah.
Okay, well, best of luck. Congrats on everyone who submitted their apps today. We're thinking of you. We're crossing our fingers for you. Keep us posted. You're all gonna do great. I know it's a stressful period, but good luck, everyone. We're thinking of you all. And John, thank you so much for presenting a case on the same day that applications are due. We really appreciate it.
Yeah, it's a great thing to have to be doing while, stuff is going on.
I hear you. I hear you. Sometimes a good distraction is great. All right, if you can get the board up, we'll get started.
Absolutely. So, yeah, let's get started. Our 60-year-old female comes into the ER with chest pain for 1 week.
All right. A fun space for me in the ER, 60-year-old with chest pain. I think how do I want to teach more than just the 4+4+2 framework here. And so maybe we can talk a little bit about sort of some of the underlying decision-making principles that can help us with something like chest pain. One of the things that we want to make sure that we always do when we evaluate patients who potentially have morbid concerns is we want to make sure that we're not missing things. And that's where really an algorithmic approach can become particularly helpful. If there's anyone here who's interested in diving more into some of the weeds about this, there's a great book out there called Noise by Daniel Kahneman and Cass Sunstein that talks about how there can oftentimes be unpredictable flaws in our judgment and in our decision making. In other words, I may see the same case, exact same clinical details 3 different times, but have 3 very different ways of going about solving that problem, usually because of factors related to noise or these sort of unpredictable things that can influence human judgment. Noise becomes a problem when we're evaluating something like chest pain because it predisposes us to have our reasoning influenced by things outside of the facts of the case. In other words, if I'm a little bit tired, if I'm a little bit sleepy, if I'm a little bit rushed, or if I'm a little bit distracted, I may work up this case of chest pain differently than I would work it up if I was less tired, less sleepy, less distracted, or less rushed. And so that's why we rely on some of these more algorithmic or framework-based approaches to the initial evaluation of things that are as morbid as chest pain, right? We want to make sure that we're not missing them. And so as soon as somebody comes into the ER with relatively acute chest pain, right, we're going to draw on that chest pain playbook and think about the 4+4+2 causes, the 4 cardiac causes, 4 pulmonary, and 2 GI causes. And we're going to think about the test that we need to at least get that exploration going, right? So we're going to be getting the EKG, the chest X-ray, the CBC, the renal panel, and the troponin, right? And that is almost a reflexive algorithmic approach up front to make sure that we're not missing or overlooking any potential key pieces of data here. The one caveat for a case like this is that this is not a day of chest pain, it's a week of chest pain. And so some of the priorities in that 4+4+2 framework may shift a little bit as a result of that. For example, ACS, aortic dissection, become a little bit less likely over a week's time frame than they would over a day's time frame. Whereas things like tamponade, Takotsubo, or pericarditis can smolder along at a little bit of a slower progression. And so they may come into the fold a little bit more given the week's tempo. The same thing goes for the pulmonary causes. Pneumothorax oftentimes presents over hours to a day rather than over a week, whereas a pneumonia or a pleural effusion or other mediastinal pathology can have a little bit more of a subacute and indolent tempo here. And a week sort of sits in between the two. It's not quite indolent, it's not quite acute. So we're sort of spanning both of those time courses. But yeah, Sharmin, what else are you thinking here just with this initial aliquot?
That was fantastic. I have nothing to add. I really, really loved how you were talking about, our bandwidth and our cognitive load and how that affects our decision making. And that's what I always like tell trainees as well, is that when I'm like really tired, I'm like, or I have a lot on my mind, then I would take more frequent pauses and I use my schemas a lot more because my brain is not functioning at its best. So it's great that we have so many awesome tools. John, do you want to tell us some more?
Sure, absolutely. So the patient was in her usual state of health until a week ago when she started experiencing moderate episodes of chest pain. The pain was mainly left-sided, waxing and waning, non-specific in nature, accompanying her spikes of anxiety, occasionally associated with mild diaphoresis, and was non-radiating, but sometimes involved her entire chest. The pain was brought upon by a stressful condition that the patient was experiencing, mildly relieved by rest and clonazepam. Today, the patient felt like her pain is more pronounced, although similar in nature. Thus, she felt like she needed medical attention, so she called EMS.
All right, I can take a stab at this, and then yeah, Jack, please jump in with anything as well. So in terms of like left-sided chest pain that is intermittent, she has like some relief with the diazepam. Again, like one of the etiology of chest pains are like panic attacks for sure. However, for me, that is always remains a diagnosis of exclusion, because if you think about like diaphoresis, intermittent chest pain, it doesn't sound that um, uh, that is like brought by like stressful situation, while like yeah, that's a good severe panic attack, but also like anything that can stress your body can stress your heart. So for underlying coronary artery disease, if that is her version of like angina or exertional, then that is like something worth thinking about as well, and thinking about like etiologies of chest pain, as Jack mentioned, that we need to rule out. In this person, I think like past medical history is also quite informative. Again, like for a lot of time, as Jack mentioned, like we think about like myocardial infarction as something that is like more sudden and acute. However, if she's having like progressive angina, and women tend to have sometimes like atypical presentations that we've come to learn, some background information has any metabolic risk factors that would again tip the scale. So uh, again, I would even though the story may sound a little bit like panic attack, I would put that aside and then go through our schema like any other patient. Jack, anything to add?
No, I think this again, the dilemma here, I feel like, is really the fact that um, once these symptoms come into the fold, um, where we land matters less at this point in the case to me than how we get there. In other words, right, we may end up at anxiety as the cause of this chest pain, right? Because there's stressful events that are happening, right? We may end up there and say, okay, the etiology of this patient's chest pain is anxiety. But as you were saying, there's so much overlap in the features there, right? Because we could say, oh, actually, a stressful event is also a stress test for this person's heart, And if we're seeing symptoms develop in the setting of an acute stressor, right, we can't necessarily falsify the myocardial ischemia hypothesis with this history here. And so I think at this point, I'm moving away from where we're going to land to what's the path that we're going to take. And the path that we take through this case is going to certainly involve falsifying all of those morbid causes that you elaborate on. And I think it's really hard for somebody who's above the age of 50 to really, from the history alone, to really move themselves out of the path through myocardial ischemia, the path through potential pulmonary disease. We may settle again on something relatively benign like anxiety, but we're going to take the journey through all of those other more morbid causes along the way.
Great.
John, why don't you take us through the next part here, up through the physical exam?
Sure. So for past medical history, she does have anxiety disorder and she is also hypertensive. For medication, she's taking clonazepam. Family history, she has a history of paternal cardiac death at 43 years old. Social history, she stopped cigarette smoking 20 years ago. Vital signs, temperature was 36.5, heart rate was 105, respiratory rate at 26, blood pressure at 180/90. She's saturating at 99%. For her appearance, she appears comfortable in bed, but clearly is anxious. She's able to provide adequate history, but reports no chest pain currently. But she does endorse some right hand pain. Pupils are round, equal, and reactive to light bilaterally. Extraocular motions are intact. No sinus tenderness. No JVD is noted in the neck, no lymphadenopathy. She is not in respiratory distress. Lungs are clear to auscultation with percussion. Good air exchange, non-labored respiration. For cardiac exam, normal rate, regular rhythm, no murmurs, gallops or rubs. There's no peripheral edema. Abdomen is soft, supple, non-distended, no tenderness to palpation. Bowel sounds are present and normal. No gross deformities of the extremities. All extremities move well with a full range of motion and strength, no tenderness or swelling. Skin is intact. Neurologically, she is intact with no gross focal deficits, and she is cooperative in an appropriate mood, affect, and thought.
All right. So I will say, I think the looking at the past medical history, I think again, what this does is it continues to support the fact that we have to at least explore all of those morbid, sinister causes of chest pain, particularly the cardiovascular cause, right? We see risk factors in terms of her age, also risk factors in terms of her underlying hypertension, and risk factors in terms of her prior tobacco use history. And when I'm saying risk factors, I should be explicit that risk factors for coronary artery disease and the possibility of that underlying coronary artery disease to be now leading to an acute coronary syndrome or more of a subacute, maybe possibly crescendoing coronary syndrome, like unstable angina that's now become an NSTEMI, or just unstable angina that's now smoldering along. There's a couple things in the exam that I think bring that up. I'll just talk briefly about the vitals here and then turn it over to you, Sharmin, for the rest. But I think the tachycardia and tachypnea, right? We may see that and say, oh gosh, that is actually moving us away from the heart into the lungs as a potential cause of this chest pain. But I think for me, the center of gravity is still around the myocardium here. And the reason for that is because of the base rate of disease, her underlying risk factors, and the fact that both tachycardia and tachypnea can manifest in the setting of an acute cardiac syndrome, right? We know that if somebody has decreased left ventricular function, right, they may start to get this experience of shortness of breath in the setting of increased left-sided filling pressures and pulmonary venous congestion. And certainly, right, any sort of painful episode, whether that's chest pain or any other sinister cardiac disease, can be very stressful, and that can also drive tachycardia. So I don't think the vitals help to decrease the center of gravity around the heart here, but I'm curious, I mean, if you're making anything from the exam or anything else from her background and things like that.
Oh yeah, thanks. Thanks, Jack. John, did I hear correctly that did her mom pass away from a cardiac? Sudden
Her
cardiac?
dad.
I'm sorry?
Is that her dad?
Her dad passed away from a sudden cardiac death.
Mhm.
Yeah, that is also another important thing to consider is that, 43, quite young. So I'm thinking about if there's any like genetic component or any kind of metabolic risk factors that run in the family, then that is something that to me is like quite significant if they have family histories of early cardiac disease. So that is like another thing that came to my mind. And I agree with you in terms of like the vital signs. Interesting that she has a history of hypertension. She's in the 180s, and I don't see a blood pressure medication. And so I wonder like how long has that been going on? Is like 180s new for her? Is that where she always is? And so that's just another question in the back of my mind. In terms of like the exam itself, again, nothing that helps move us forward in a diagnostic way. Again, like you can say like we don't hear any crackles, right? Like there's no rhonchorus, like, so I don't think it's a pleuritic chest pain that points toward like a pneumonia type picture. But again, like you would like get your chest x-rays, again, like ED rooms are quite nosy and busy. So I often question my exam whenever I'm in those rooms. So but you know, don't see elevated JVP and all those things. But as Jack mentioned, I think first and foremost, this is someone who I would get an ECG on, we get troponins in. And the other thing to also consider, you know, thinking about kind of vascular pathologies that often are silent on exams. So like pulmonary embolism, like, you know, we don't really hear the vessels when we listen to the lungs. So for me, like the numerous diagnoses are here are like the vascular pathology. So that's where I'd be honing on getting our basic labs and then troponin ECG first, and then see what that shows. Jack, anything to add?
I love it. I'm so glad you picked up that piece of the family history. I totally missed that.
It's a team sport, yo.
This is awesome. So while we wait for our chemistries to come back, allow me to share the ECG. Oh, hold on. Could the host allow me to share my screen, please?
Yeah, I just did. Sorry.
Okay, thank you. There we go.
All right. Well, I will just briefly run through some things here, saying that we're not necessarily, I should say, looking at this in isolation rather than compared to a prior. There's a few things that stand out here, right? So I'll jump through the sort of usual things of rate, rhythm, and axis. It looks like it's maybe a little bit fast, maybe like around 110-ish or so. So a little bit of a fast rate. The rhythm looks like it's sinus. It looks like we have a P before every QRS, a QRS before every P. We say an upright P wave in lead 2 and a biphasic P wave in V1. And then the axis looks to be normal. So then if we start to look at, okay, well, what's the real hypothesis that we're testing for here? We're looking at the ischemia hypothesis, as we said, with chest pain. And if we look and see, okay, let's just look and see if there's clues for ischemic changes. Those ischemic changes being ST elevations, ST depressions, and T wave inversions. Sharmin, I'm going to tag you in here as I'm going. I'm seeing ST depressions in 1, 2, 4, 5, 6.
Like maybe AVL too, yeah.
And then looks like maybe some elevations in 3, but not AVF. And then maybe also some depressions in AVL.
Yep.
Yeah. And then maybe some elevations in AVR.
Yeah, I was like curious about that one. So yeah, you know, when you see kind of like diffuse ST segment changes, you sometimes like worry about like pericarditis type picture. However, I think like baseline would be helpful here. And you know, taking history back, just presenting with like 1 week history. So the question is, if you're seeing this ECG in the ED, are you calling STEMI or not?
Yeah, it's a good question.
As ED physician, Jack, how do you think about it?
Well, I will just sort of talk to like if I was going through this, you know, I think we might feel compelled, as you were saying, to say there are diffuse ST segment changes on a 1 week history of chest pain that could totally be compatible with pericarditis. Distilling pericarditis from an acute myocardial infarction is a really challenging dilemma, right? We learn about the diagnostic criteria for pericarditis as a very specific things. Is there a compatible chest pain syndrome? Is there evidence of a pleural effusion? Are there compatible ST or are there compatible EKG changes? And we really need 2 of those 3 to make the diagnosis. But one of the things that's hard is that the compatible chest pain syndrome can look and sound and feel a lot like the compatible ischemia syndrome. And the Compatible EKG changes can also reflect underlying ischemia. So this goes back to the principle that we talked about at the beginning, which is we may settle on something here, but the journey that we take to that destination matters a lot more. And I think in this case, right, if we were to say we have risk factors for underlying CAD, a history that could suggest a smoldering coronary artery process or a smoldering coronary syndrome, and EKG changes that support that, right? We can't falsify the ischemia hypothesis at this point in time, which we would need to do before we settle on the pericarditis hypothesis. And so I think at this point here, right, we don't necessarily meet criteria for a STEMI because we have ST elevations only in one lead rather than in contiguous leads. But I would say that we have very, very concerning EKG findings that could suggest underlying ischemia in somebody who has known risk factors and a chest pain syndrome that's not incompatible with ischemia. So I don't think I would activate the STEMI pager here, but even in the presence of a negative troponin at this point, I think I still would call cardiology right away. The reason for that being, right, unstable angina can be a troponin negative syndrome and can unfold over a week like this. And then the other thing being the fact that the earlier we can potentially mobilize resources to get her to cath, the better.
Oh, I absolutely love that. I totally agree with you. I would be thinking about ischemia and I would call cardiology and send them the ECG. And just elevation in AVR makes me worried. Like thinking about if this is a proximal, like a left proximal LAD or like kind of left main disease, or like kind of bad triple vessel disease. And again, if you're invoking that maybe this is a stress, then we're bringing out a terrible, like really bad triple vessel disease into someone who has family, like history of coronary artery disease as well, early onset. So I agree with you. Like I would see what the troponin says, but yeah, definitely a low threshold to call your friendly cardiologist.
Sure. I mean, I think just to build, double down on the point that you said about the proximal left main disease is that AVR, like proximal left main disease, can give us global ischemic changes in one AVL and the anterior and precordial leads here. So it's such a great call that global ischemic changes could come from a global process like pericarditis, but it could also come from ischemia in a huge, huge vessel. So I love that call that you made about the AVR elevation and the possibility of left main disease.
John, you have us at the edge of our seat. I'm getting palpitation.
So as we just finished the ECG, so now our labs came back. Pertinent labs are WBC of 18.31, a glucose of 180, and a troponin of 11,000. Cardiology was consulted, and it was read as to consider an ST elevation, an inferior injury, or acute infarct.
Yeah, so maybe we can just talk briefly about yeah. Again, like I think like the leukocytosis back in the day, one of the first markers of acute myocardial infarction was leukocytosis, right? Because of a stress response. So that's when that is of like chucking it up to that. The troponin very elevated, again, kind of speaks to the degree of ischemic changes that we also saw in the ECG. So then the question was in terms of like management, now that you're worried about like whether she's having active ischemia, what are we going to do? So, you know, I think calling STEMI is totally fair. At this point, a cardiologist is already involved. So this is someone that I think should go to cath lab soon, just to make, again, just to see what we see. In terms of management, you know, aspirin, definitely statin, great. She's a little bit tachycardic, and I think the question is like if you're not really worried about right-sided, then a bit of beta blocker might be helpful. In terms of like, oftentimes you want to dual load them with Plavix as well, but oftentimes if you have a worry about the triple vessel disease, cars might want to hold off until after the procedure. So that's like something that I always ask our cardiologists whether they want to dual antiplatelet therapy up front or not. And you know, oftentimes like heparin is what we breach them, but if this is a person that's going to go to cath lab immediately, we can hold off on that. And the other one is like kind of like blood pressure management. I think I would just start by a beta blocker because again, you want to decrease the demand on the heart. Jack, that was me pretending to be an ED doc.
No, that's it. I think, yeah. I have absolutely nothing to add. The only I may have missed it because I was responding to something on here, but afterload reduction sometimes here, but it's not the biggest help probably in these first few minutes, as it is going to be over the long term to prevent further remodeling. But if we're worried that that blood pressure is causing demand, that is going to be further exacerbated by the underlying tachycardia. And if you are going to reach for afterload reduction, it can be helpful to not reach for an agent that will promote reflex tachycardia. So hydralazine here would be, I'm not going to say the wrong choice, but maybe a suboptimal choice, because that pure afterload reduction can sometimes lead to a compensatory tachycardia, or at least hydral can do it. But a little bit of captopril can go a long way to help kind of offloading that LV and trying to optimize things in that sort of acute but critical pre-cath period. And again, I think it's also important to say that, right, that the cath here is not to treat an acute myocardial infarction, it's to test for it, right? So the cath becomes first off a diagnostic test for the coronary angiography. And then there's a possibility that that's going to be a negative coronary angiography. And then we have to say, okay, what's the cause of the myocardial injury if it's not myocardial infarction? But if that cath is positive, which I think, Sharmin, as we've been saying, like it seems very likely that it is, then we move to the management side of it, which is going to be where we don't, but the interventional cardiologist does, and she'll place a PCI or place a stent wherever one or many need to go.
Speaking of imaging, I do have one image I'd like to from the cath lab. Here we go.
Ooh, that seems like almost total occlusion. Don't ask me which vessel that is. Is that the
So it's
LAD?
the LAD.
Just guessing. Yeah. I was just gonna guess LAD just because of the way she presented it, but it's been a while since I looked at the cath lab, so thanks for bringing this up.
Yeah, I wish I had the video, because it was really cool to see it fill and then trying to figure out which one was blocked. And then it became pretty apparent as it was read as 99% occlusion.
Yeah. Oof. Did they end up placing a stent, John?
Yeah, one drug-eluting stent.
Yeah. Again, like these like proximal lesions, especially if it's an acute when again, like the heart hasn't had time to compensate and build collateral, kind of like can present as this kind of diffuse ST segment changes with like a depression. So, and then like that AVR, like I think is a good thing to remember, that when you see elevation in AVR, a pause and think about kind of like left main proximal LAD disease at that point. And so, sometimes like Takotsubo can mimic that as well. So what a case. Jack, what are your thoughts?
I just love cases like this because I think, again, just coming back to, when we think about wanting to be effective reasoners, it's a decision-making process. And in decision-making, yes, in some ways depends on the outcome, right? Did we get the right diagnosis? But again, I think this case highlights that the path we take to that diagnosis matters so much more. And that's where, right, thinking about even if at the beginning we don't have a clear history that, oh, this is definitely ACS, but we almost flip the script for these very morbid diseases and we say, can I falsify this hypothesis, right? So for morbid diagnoses, we want to be focusing on falsifying the hypothesis up front rather than proving it. And as the case unfolded, right, even before we got to the elevated troponin and the EKG, there was nothing that we had that said we could falsify the acute coronary syndrome hypothesis, even if there's compelling things for alternative causes, right? Oh, it got better with clonazepam. Maybe it's anxiety. Supporting a less morbid diagnosis is much less valuable than falsifying the morbid diagnosis. And I think this case highlights the importance of really focusing on that in the initial steps for any sort of chief concern, right? Whether that's acute abdominal pain, subacute chest pain, hypoxemia, right? Any of these morbid initial chief concerns, we want to focus our energies on falsifying the morbid hypothesis first. And right, every step along the way, we could not falsify it, right? The EKG and the troponin coming back doesn't prove ACS. It just keeps us from falsifying it and also makes a very strong case for it. And ultimately, it's not until we get the patient to cath lab. And I think the other reflection there is that one of the things that I have appreciated so much in getting to learn from the interventional cardiologist is that if every time we cath somebody, we're finding significant disease, then there's probably not enough caths that are being done. In other words, right, really treating the cath as a diagnostic test, which it initially was here before it was therapeutic. And so our job, at least my job as a generalist in the ER that I end up thinking about a lot is this somebody where we need an expert's eyes to make this right? Has this person crossed my threshold to get someone else's eyes on it? And that's a much easier question to answer than does this person definitely have an acute coronary event or not, right? So where we set that threshold to call cardiology in this case, right? We set it, that threshold was in the right spot. I think those two principles of like, what's the path that we're taking and to a diagnosis, and do we have enough information to falsify a morbid diagnosis, as opposed to can we clinch the diagnosis? Because oftentimes we're not always in the business of clinching a diagnosis. We're in the business of trying to falsify it, and if we can't, reaching out to somebody who could help us falsify it or who could help clinch it.
No, that is such a great point. I am still like blown away, right? 1 week with a proximal LAD. Like the question is like, did that happen in that process? And the other thing that I would do, I would probably get an echo on this patient. Because again, like we're not sure about the duration. I mean, the fact that she presented with like kind of stable-ish vital signs and like intermittent symptoms, again, like I just continue to be humbled by the spectrum of ACS presentations, but just to make sure in terms of like ejection fraction, like how it's doing, if this has been going on for a while. So I would like get an echo as well, and then see if there's any other medications that we need, in addition to hypertension management that Jack alluded to earlier. Well, John, any other thoughts or reflections from this case? Thank you so much for sharing. This is like such a great educational case.
This was an interesting one for me because I was an extern at MedStar at around 3 p.m. and I leave at 5. We get a call to see someone in the ER for this reason. And then like at that time we had propofol infusion syndrome, a bunch of respiratory failure patients from COPD, and then you're thinking 1 week of chest pain. That doesn't sound like, all right, we'll go see them. And then in the beginning of the presentation, Jack said something about noise. And then while we were going down, there was a lot of noise. Like, this is just probably anxiety. This isn't probably ACS. Then after the ECG, cardiology was consulted. We sent her the cath. We found that she had a 99 occluded LAD. We're like, oh boy. Good thing for those algorithms that we have to follow, because we may have lost her. But after everything in the ICU, she was clearly a very anxious person, like someone with a very high sympathetic drive. So I think a lot of her hypertension is brought upon by that. So maybe if her anxiety was more well controlled than just a low dose Klonopin, she might have had better outcomes, or may have probably prevented her ACS. But it's anyone's guess from that point on.
Yeah, thanks so much for sharing that. I appreciate it, John, and I'm glad she did okay. And this was found. And yeah, like anxiety is challenging, management of it is challenging. It's like how people respond to the world, and to think that this could have been missed because of that. It's a good lesson to remember that anxiety, panic attack, you just have to prove to yourself that there's nothing else going on. It's always a diagnosis of exclusion. So we should consider it, put it on a differential, but never land on it from the get-go. And whatever we can do to help support her, because I can only imagine like having a heart attack is stressful enough. And then if you have underlying anxiety disorder, that can just make it so much more tough. So yeah, thank you for taking care of this patient and sharing her story with us. I learned a lot. Jimena, we are ready for you.
I am ready, and thanks to all of you for presenting this case. I think that you're very right in the sense that sometimes we don't take very seriously the symptoms of patients when we think that they have an anxiety component, but as one of the teaching points is going to be, first rule out important things, and then you can more confidently say that. So at the start of the session, we learned that algorithms are a great help. They can help us reduce the noise when we have some clinical presentations that might be subjective to clinicians' judgment or cognitive load. So if we have them, we have to use them. They are great resources. And also, getting a little bit back to what we were talking about is ruling out life-threatening conditions related to chest pain. Sometimes when you have patients with panic attacks, we got to remember that that is exclusion, a diagnosis of exclusion. And it is really important to discern, like, what is the emotional involvement and the stress that a patient might be going through versus what conditions can actually put a big strain on the heart. We can also use past medical history to guide the probability of patients to actually have an MI, as it was in this case, or other non-life-threatening conditions. We also have to remember that tachycardia and tachypnea can present in the setting of MI or pulmonary disease, not just pulmonary disease. And think about how the family history of relatives passing away at a young age should also raise concern about cardiac risk factors and should elicit more questioning about it. Another thing that is helpful in the setting of MI is just to assess the comorbidities of a patient, and especially if they are metabolic comorbidities, how well controlled they are. That can help us increase or decrease the probability of them actually having an MI. Also, diffuse elevations or diffuse changes on ECG can raise concerns of pericarditis, so that was a great pearl to remember. And in the workup of the ED, we can consult a cardiology early. It is very helpful to involve them in the case, especially when the patient is going to cath lab, because they can bring good input over like anticoagulant and antiplatinum therapy, because they're going to be the ones performing the procedure. And another great pearl was that sending patients to cath lab can be first diagnostic and then become therapeutic. That was a good reminder. And this goes back to, I think, which is the biggest teaching point, and is that we have to think about interventions that we can make to support or to rule out a diagnosis. And if we can't rule it out, we can keep testing until we can be more confident in the probability of a patient having a particular disease. And this becomes more important in conditions that can compromise a patient's life. And the last pearl is that elevations in AVR can point to occlusions on the LAD.
Oh, beautiful. That was awesome. Thank you so much. And David, thank you so much for subscribing as well. Y'all are awesome. Jimena, beautiful job. John, thank you so much for presenting the case. Thanks again, all. We'll see you tomorrow. Have a good day. Bye.
Having you guys. Bye.